Yeah, so go ahead. It's recording.
Thank you once again, my chiefs, my consultants, and my colleagues. Today, I will be taking questions 201 to 205. So question 201 says, which of the following is a feature of renovascular hypertension due to atherosclerosis as opposed to fibromuscular hyperplasia? A, age less than 60 years. B, female gender. C, no history of hypertension. D, progression of more likely to complete renal artery occlusion. Then E, absence of carotid bruise. So this question is asking for a feature that is more in keeping with atherosclerosis than fibromuscular hyperplasia. Then, first of all, we need to know that renovascular hypertension is one of the most common causes of secondary hypertension. And we have two major types of renovascular hypertension. The first one is actually due to atherosclerotic cause, while the other one is due to fibromuscular cause. Then for the atherosclerotic cause, it affects the proximal third of the main renal artery, and it's more in men, and the older men to be precise. Then the prevalence is actually higher with advanced age, and also in patients who have diabetes, and when there's an evidence of atherosclerosis in other arterial beds. That is for atherosclerotic cause of renovascular disease. Then for the another cause of renal atherosclerosis is also fibromuscular dysplasia. This one primarily affects women who are aged 20 years to 60 years. And it involves mainly the distal two-thirds of the main renal artery. So the renovascular etiology itself should be suspected in patients who have high blood pressure before the age of 30 years, or even after the age of 50 years. And it's worth to know that this question is asking for the one that is actually more indicative there. So the patients who have atherosclerosis, they're actually older and they have a high systolic blood pressure. So, and patients who have fibromuscular hyperplasia are younger and they are more female, and they have no family history of hypertension, and they also have less evidence of target organ damage. Then patients who have fibromuscular dysplasia are actually less likely to progress to complete renal artery occlusion, unlike patients who have renovascular hypertension due to atherosclerosis. So going back to the question, it says, which of the following is a feature of renovascular hypertension due to atherosclerosis as opposed to fibromuscular hyperplasia? Age less than 60 is false. The female gender is false. These are more in keeping with fibromuscular hyperplasia. No family history. So the correct answer to this question is D. It has progression more likely to complete renal artery occlusion. So the answer is D. Then question 202. Please, can you take it up? I can't see it well here, please. Can you take it up, please, for question 202? Oh, no, you've passed it. Please, can you go down? Thank you. Thank you. It's cool now. Question 202. A newly diagnosed diabetic patient presents with multiple blood pressure readings that are 150 and 90 millimeter mercury or higher. Which of the following statements about treatment of this patient's hypertension is not correct? They are looking for the false answer here, the incorrect answer. Current guidelines recommend a BP target of less than 130 over 80 millimeter mercury in diabetics. Obviously, this is a correct answer. Control of blood pressure reduces cardiovascular events rates more in diabetics than in non-diabetics. This is actually a correct answer. Pharmacologic blockade of the renin-angiotensin system reduces the risk of both microvascular and microvascular events. This also is a correct answer. Antihypertensive therapy with dihydropyridine calcium channel blockers reduces cardiovascular events. Of course, this is a correct answer. So the wrong answer, the not correct answer there is aggressive BP control in diabetes has been shown to reduce cardiovascular events rates more than a target systolic blood pressure of less than 140 milliliter mercury. So this question is a straightforward answer. If you are looking at it, so The correct answer is E. The incorrect answer is E. Aggressive BP control in diabetes has been shown to reduce cardiovascular event rates more than a target systolic blood pressure, less than 140 milliliter mercury. So I don't know if anybody has a question, or should I continue?
Please come again. You said just come again, starting with the E. I'm not sure I get it.
They said which one is not correct. They're looking for the incorrect answer. They said aggressive BP control in diabetes has been shown to reduce cardiovascular events rates more than a target systolic BP of less than 140 millimeter mercury.
And
Can you hear me?
yeah, I can.
So
It's
the
true
reason,
now. Aggressive
no,
BP
actually,
control.
what happened? If you're looking at this question, it's what. Well, why I said it, there is this trial they did. They called it their core trial. They were actually looking. They wanted to do a very aggressive BP reduction in systolic blood pressure for less than 120, and they found that there was no more difference. So that was why this E for me was the incorrect answer. The one I was going to
Okay,
is
I understand.
there was a study they did known as their core trial. So their core trial did not really. That was why. So that's why I went for this C.
Okay. So there was no significant benefit
So what their core
of
trial said that there was a very aggressive. Yes, there's no significant benefit.
benefits of excessive BP lowering to a target of less than 120. Okay, I get.
Yes. So this is an accord trial they did. So that was why that's answered. So question 203. Please, can you take it up, please? It's quite tiny here. Just a little up, please. It's left again.
If I take it up, it will move into the next page. I don't know, but you can see it. Or should I zoom it more?
Okay, all right. Question 203. Which of the following statements regarding the use of percutaneous coronary intervention as primary therapy in acute ST segment elevation myocardial infarction is not correct? So they're looking for false answer in this. PCI is associated with lower rates of intracranial hemorrhage than fibrinolysis. The primary success rates for PCI during acute STEMI is approximately 90%. In trials comparing primary PCI with fibrinolysis, patients with randomized to primary PCI had a lower incidence of death or reinfarction by hospital discharge and at 6-month follow-up. I can see the next. Can you bring the other? Maybe you go up the later.
Yeah, can you see it now?
Yes. Then D, primary PCI does not improve survival in patients with acute STEMI who present with cardiogenic shock. Then E, one performed in experienced centers, hospital length of stay and follow-up costs are significantly less than for patients treated with fibrinolysis. So it's of note to know that PCI for acute ST segment elevation has several important differences and advantages when you compare it with a pharmacological fibrinolysis. Now, it's so that the success rates with the safety and the success rate in establishing reperfusion of more than 90% is superior to that of fibrolytic agents. So it's recommended that patients do get PCI if the patient needs at that point, and patient can get it at that level. And there is a less likelihood of developing complications such as reocclusion, reinfarction, and stroke with primary PCI. There's also some studies that have been done, and they demonstrated that a primary PCI, when you perform it at an experienced center, it results in a significant reduction in the rates of death. And also there's a reduction in rate of reinfarction and stroke, and also hemorrhagic stroke compared with fibrinolysis. Also notable that in addition, primary angioplasty has also been associated with shorter hospital stays and lower follow-up costs. And patients who present with an acute MI and coagulation are a high risk of death and cardiovascular complication. But there's this shock trial that they did where about 302 patients were involved and with cardiogenic to early vascularization. They found that the early vascularization with primary PCI or urgent bypass surgery was associated with improved clinical outcome about survival at 6 months. So when you go back to this question, it says which of them is not correct. So they are looking for the wrong answer. They said PCI is associated with lower rates of intracranial hemorrhage than fibrinolysis. That is correct. The primary success rates for PCI during acute STEMI is approximately 9%. It's actually correct if done early. Then in clinical trials, comparing PCI with fibrinolysis, patients randomized to primary PCI had a lower incidence of death or infraction by hospital discharge and at 6 months follow-up. That is actually correct. Then primary PCI does not improve survival in patients with acute STEMI who presented with cardiology. That is incorrect answer. They actually improve its survival. Because I just talked about the shock trial that was done for patients who have cardiogenic shock and they receive PCI. So the answer to that question, 203, is D. The incorrect answer is D. Ideally, patients improved. Patients who had PCI in cardiogenic shock, they actually improved. So the incorrect answer there is D. So if there's no question, I'll move back to question 204. No, please, can you go up a little? Yeah, question 204. A 67-year-old man with hypertension, elevated low-density lipoprotein. Just please, you can actually reduce it so that I will see the whole question. I'm seeing just very few. All right, can you see this? It remains later so that I'll see the whole. Okay, yeah. A 67-year-old man with hypertension, elevated low-density lipoprotein, cholesterol, chronic obstructive lung disease, and gastroesophageal reflux presents to the emergency department describing 1 hour of 8/10 substernal chest pain, pressure rather, that radiates to the left arm. He had previously been healthy with no known history of coronary disease. Though he led a sedentary lifestyle with little physical activity, his medications are aspirin 81 mg daily, lisinopril, lisinopril 40 mg daily, atorvastatin 40 mg daily, and omeprazole 20 mg daily. Vital signs in the emergency department include a temperature of 37.2 degrees centigrade. Heart rate was 92 beats per minute, blood pressure 160/93 millimeter mercury, respirations 20 breaths per minute, and oxygen saturation of 98% on room air. Physical activity reveals a well-developed man in moderate distress with jugular venous pulsation at 8 centimeters of water, clear lungs, regular health, heart rhythm with no peripheral edema. The ECG shows normal sinus rhythm with normal intervals and axis and 3 millimeter ST elevations in leads V1 to V4. He is taken emergently to the cardiac catheterization lab. 2 angiographic views are shown in figure 2.2. Which of the following interventions would be most appropriate? So I don't know if it's possible, you can see the pictures. A, percutaneous intervention of the left anterior descending coronary artery. Okay, this is it. This is a picture of, okay, can go back up. Now, percutaneous coronary intervention of the left anterior descending coronary artery. You've removed it, please go up. Okay, percutaneous coronary intervention of the left anterior descending coronary artery. Now, and consideration of PCI of the left circumference and the right coronary artery at the same time, or as a staged procedure. B, PCI of left anterior descending now. Avoid additional PCI of left circumference and or right coronary artery during that procedure. Then C, percutaneous coronary intervention of left circumference now. Additional PCI of left anterior descending and the right coronary artery to follow at same setting or a staged procedure within 45 days. Then D, PCI of left circumference only, then additional PCI of left anterior descending and or right coronary artery should be avoided. So obviously, this is an image that was taken. Okay, we've seen it. That's an angiography that was done on the patient. So the image on the right is the right anterior oblique, while in the left is the left anterior oblique. Honestly, I may need some seniors to explain this imaging more. But when I read about the question, I found out that they said the image on the right is the right anterior oblique of the left coronary artery, and it shows a total proximal occlusion of the left anterior descending artery. Then they said that the presumed culprit lesion is there. Then within the mid left circumference, there's actually an 80% stenosis. While on the part B is a left anterior oblique view of the right coronary artery. And it showed a 60% stenosis of the mid vessel and 90% stenosis of the distal vessel. So, but in general, they said approximately half of the patients who undergo coronary angiography for ST segment elevation, myocardial infarction, they have a multi-vessel disease. And initially, PCI of a non-infected related artery at that same time of PCI in hemodynamically stable patients, they rated it as a class 3 procedure, according to American College of Cardiology. Then there've been a lot of trials that have been done, including the PRAMI trial, the Dynamic 3 pre-multi trial, and the PRAG 3 trial. These are actually trials that have been done for patients who have actually had this coronary angiography. But obviously, I really don't understand this angiography well, but when actually I read about it, looking at that, they said that what you should do, going by the questions, is to do a percutaneous coronary intervention of the left anterior descending coronary artery now. Then you now consider a PCI of the left circumflex and on the right coronary artery at the same time or as staged procedure. So when I call the answer I saw for that is A. So they said A is the answer. Well, I don't know if any of my seniors who has better information could please help me us explain this angiography more. So, but the answer to the question is A. If not, or I can go to 205.
Okay, correct me if I'm wrong. Maybe someone can correct me if I'm wrong. But if you look at this artery here, of course, this is RAO caudal. This is the left main coming out here. But I am not 100% sure. But like we all know, the left main gives off circumflex and the left anterior descending. But since they said there's a total occlusion, this artery like stops here. telling us that you can't see any other thing from
beyond
here.
that point.
You can't see another thing beyond that point. Then this is the circumflex. So there's also some occlusion here.
Occlusion there. Yes.
Here. So this is what I think they are referring to as, how many percent did they call it again?
I think it's a 60%.
60% of the circumflex. Yes.
Yes.
Then if, of course, this one is the easiest to identify because you can see the right coronary artery. Just this one is just the right coronary artery. So I feel there are occlusions in the mid right coronary artery, that's here, and in the distal right coronary artery, that is here. But this is me walking from back to front. If you ask me to walk from front to back, I may not be able to. I don't know whether you understand me. I may not be able to get it. But I think that's what is going on here. Like you said, the from the I think the way to even to get this question is to look at what they said about the ECG, because they said there is ST elevation in V1 to V3.
One to V. So it's more about
yes, that's actually how to know the culprit lesion. So that tells you that it is this one that is the because culprit. This is what will supply the anterior aspect.
Anterior aspect.
Yeah, so this one that is the culprit.
The septal aspect.
Yes. So that's what I don't know if someone can help to make it better, but that's actually what I think.
Please, can I see, Dr. Kure, well done. Actually following you, but are we sure that the one you call the circumflex is the circumflex? Is as if it goes further to divide into two now?
Into two. Yes, I can see it here.
Yes, so that looks like, and the one that goes and divides into two is what now? That gives this thing, that's the left anterior descending. So I think it's the other way around for this one. Do you get what I'm saying? The circumflex does not give a terminal two branches that we are seeing here.
Yes,
so
I get what you're saying.
Yeah, so this is the main LED, and the other one that was completely cut off will be the circumflex now.
Circumflex, okay.
You understand? Going by the anatomy, that's one. But let me see this question, because let me see the question. Question
204.
Well, let me read the question.
Okay, let me scroll back up. This is the question.
Okay, it's a long question, yes, because the way I was saying it, when they talk about the corporate this thing, there's this study. Okay, let me mention at this point that all the studies especially for MI, PCI, I think I've said that before. We have no choice than to just go and read them and cram them. What was done and the how will I put it now? The or the outcome, yes, let me put it that way. The outcome, the drugs that were used, and if it's procedural, you should know the procedure that favored, you understand? So this one now we are talking about PCI and what's the name now? And open surgery, that's garbage. Do you understand? So at times, yes. So at times when we have heart failure following, or let me say when we have an MI involving multi-vessels, do you get? And patients are not they are not fit for surgery. Let me put it that way. From maybe different reasons, you understand? They tend to do like a stage PCI. So by stage PCI, they would like stent the corporate vessel and see if patients will regain function of the heart and will get better. Do you understand? We'll allow collaterals for the remaining that you cannot go after. But even now, they now can even do stenting of two vessels instead of coronary artery and bypass grafts, depending on the clinical scenario. So I think this question now is like a trial question where so the corporate vessel will be that if majority of the heart is supplied, most of the blood supply for the major part of the heart that supplies the right ventricle, that could make left ventricle, especially in those who present with failure or decompensation
Session.
or decompensating, yes, symptoms following an MI is usually the left main, that's the left anterior descending or the
Descending.
left main, yes. Or maybe when you have extensive or widespread and patient is not fit for surgery, they just stent the left coronary. So that's what he's telling us. They can now do maybe stage later, or they take the patient back later. But to save the patient, the trial has said that you just stent the corporate vessel. You know, in the case of, let's say for instance now, patient has an MI, now presented instead of tachycardia, you are seeing complete heart block, and patient is symptomatic. You understand? Maybe it's in failure with a complete heart block, or maybe right ventricular infarction, or any form of failure the right side, and it has a block. In that instance, now, if I may ask, which will be our culprit vessel?
Mm.
It will be the right coronary, because that is in most cases, in 60% of cases, we have the supply of the SA node from the right coronary.
Coronary artery,
And
yes.
now, yes, and patient has like a complete heart block, and we have features on the ECG of maybe inferior, and patient is in failure, maybe from right ventricular infarction or something. So the vessel you go for will be the right coronary in that
RCA.
instance. Yeah, even if you have some of obstruction or occlusion of the left, but at that instance, you need to save the life of the patient. You are in the cath lab. What will you do? You go after the
RCA.
right, because you know when you do that, there will be perfusion to the SA node, and the right ventricle that is failing will pick up, and you see if patients would, you understand, at that point
Yeah.
to improve. Yeah, so that's what the trial was about. So either you do a state PCI, you first do the corporate, then you go back, or maybe later if you can't now and then do the lab. You just do one that you feel will
It's most important.
improve the patient's, yes, most important at that point in time. So that's what I can say. I don't know if that sheds light on what this thing was about the corporate vessel. Or you want me to read through this question? I was not following the question, but it's actually a trial, or is this thing. I don't know if that helped.
Chief, I get your information. Hello,
Huh?
Dr. Charles.
Yeah, Chief, he helped a
Thank
lot.
you very
It
much.
helps. It
Okay.
helps. It helps, man.
Sorry, my network has not been good today. But boss, hello.
We can hear you, sir.
Go ahead, we can hear you.
Yeah. Okay. So just as our consultant just mentioned, I think one of the significant trials that informed the guidelines with respect to corporate or infarct-related artery and non-infarct-related artery is a complete trial. So we could look at that trial, trying to advocate for complete revascularization as much as possible. And that's where the staging of the PCI comes in. And if you look at the guidelines, they looked at within the 45 days from the index PCI. And what will define whether you do it on the same day as the index PCI depends on how stable the patient is. So for very high risk patients, you want to go for the corporate vessel. But with the diagram that was shown, before I went off, I think there was concern whether the bifurcation, the artery that was coming off was actually from the LSEC or not. Now, you can have a very large OM branch coming from the LSEC that can sometimes make it look like it is not the LSEC, because the LSEC literally should have branches from one side. So I'm thinking, yes, from an RAO view, that cuts off completely is the LED, and that's the one below is the LSEC. Just that it has a very large OM1 branch. That is making it look like it's bifurcating. So I think those are OM branches that are coming off the LSEC that that one is quite big, because if you turn it otherwise, then RAO view, that is where the LAD should be, and that's where the LSEC should be for an RAO call down. So I still think it was the LSEC that has about 80% before that branch, the huge relative OM branch coming off, and the other one is still 100% occlusion of the LAD.
Okay. Oh, thank you, Dr. Eugene.
Thank you, Dr. Ish. All right, Dr. Dina, I think you can go on.
Okay, question 205. It says, which statement about atrial infarction is false? So they are looking for a false statement about atrial infarction. It said, A, atrial infarction is found in less than 20% of autopsy-proven cases of myocardial infarction. B, atrial infarction typically occurs in conjunction with left ventricular infarction. C, rupture of the atrial wall is a recognized complication. D, atrial infarction commonly leads to supraventricular arrhythmias. Then E, infarction of the left atrium occurs more commonly than infarction of the right atrium. We are looking for the false answer. Now, we need to know that the atrial infarction occurs about 7 to 17% of patients who have autopsy-proven cases of myocardial infarction. When they've done had myocardial infarction, possibly we did an autopsy, about 7 to 70% of them had this atrial infarction. And it's worth to know that this atrial infarction is often seen in conjunction with patients who also have a left ventricular infarction. So both can occur at the same time. And they're actually more common in the right atrium than the left atrium. So this atrial infarction most has to common in the right atrium. Now, they also need to know that the difference may reflect the presence of a well-oxygenated blood in the left atrium. And this will also help to nourish an ischemic atrial wall. Then most of the atrial infarctions have been shown to have a supraventricular arrhythmia that occurs with it at the same time. Also, they may also have some form of atrial fibrillation, and they may also have some form of sinus arrhythmia. Then also atrial infarction is also known to be complicated by a rupture of the atrial wall. So if you are looking at the question they asked, they are looking for the false answer there. They said which one is false about atrial infarction. And going by what I just explained now, that is actually occurring about 7 to 17% of people. You see that less than 20% that make this option A to be correct. Then atrial infarction typically occurs in conjunction with left ventricular infarction. I already said it can occur with it. It can occur in isolation and can also occur with also left ventricular infarction. And like I said, the atrial wall can also rupture when this infarction occurs. And they can also have some form of arrhythmias in conjunction with this atrial infarction. So the false answer is E. The infarction of left atrium occurs more common than right atrium. That is not correct. It is the right atrium occurs more than the left atrium. Infarction of the right atrium occurs more than the left atrium. So if you're looking for the false answer, the false answer in this question is E. That is option E. That is the false answer there. That ends my question for the day. So I don't know if there's any question. I'll move on.
All right. Thank you so much, Dr. Denaka. Let me just add that the difference in this, the reason why infarction in the right is because of the blood. Since the blood in the LA is more oxygenated, so it's been less prone to infarction, while the right is deoxygenated, so it will be more prone to infarction. So thank you so much for, first of all, the presentation, then also for the MCQs. We are grateful. All right, so we'll move on to question 206. Thank you, sir. Question 206. Yes, Chief, you want to say something, ma?
Good evening.
Yes, go ahead, please.
Okay, I'll be taking 206 to 210.
Okay. Okay, go ahead, go ahead. Go ahead, Dr. Kedar, go ahead.
Which statement regarding ventricular free wall rupture complicating myocardial infarction is not correct. A, it is more likely to occur in patients with a history of prior myocardial infarction. So we are looking for the option that is not correct. B, it occurs most commonly within the first 48 hours after infarction. C, it is more common in elderly patients and in women. D, a history of hypertension is a risk factor for free wall rupture. So the rupture usually occurs at the margin between the impacted myocardium and the healthy myocardium. And risk factors for it include absence of prior myocardial infarction. It's believed that if there's been a previous myocardial infarction, there is a scar tissue already formed, and it makes that myocardium less prone to rupture. Then other risk factors include elderly or advanced stage, female gender, the history of hypertension. Those are risk factors for it. So I'll go back to the question now. So this D is a true statement, and we're looking for a false option. So C, more common in elderly patients and in women, is also a true statement. Then it's true that it occurs most commonly within the first 48 hours after infarction. It's been found in, I think, 1 to 2%. Then option A, it is more likely to occur in patients with a history of prior myocardial infarction. So this is the false statement. Because like I said earlier, if there is a prior myocardial infarction, there is a scar tissue that is already there, and that myocardium will be more resilient and less prone to rupture. So the answer for question 206 is A. That's the false option. I don't know whether there are contributions. Oh, I should go on. Okay. 207. Which statement about right ventricular infarction is false? A. Right ventricular infarction is a cause of proximal sign. B. ST segment elevation in lead V4 is commonly present. C. Echocardiography typically demonstrates right ventricular enlargement and hypokinesis. D. A marked hypotensive response to nitroglycerin administration is consistent with this diagnosis. E. Atrioventricular sequential pacing offers greater hemodynamic benefit than single-chamber ventricular pacing in patients with right ventricular infarction. So we are looking for the false option. So, right ventricular infarction is a cause of personal sign. That is a true statement. Personal sign is paradoxical elevation in JVP with inspiration. So you can find it in any cause of right ventricular strain, constrictive pericarditis, and also right ventricular infarction. So it's a true statement. So it's not our guy. B, ST segment elevation in lead V4 is commonly present. So for right ventricular infarction, you need to arrange the electrodes such that you will have a V2, V3, V4R. So, and it's in V4R that you will see that ST segment elevation, not the standard V4. So this option B is a false statement. C, echocardiography typically demonstrates right ventricular enlargement and hypokinesis. That is true. For a right ventricular infarction, you would see dilatation of the right ventricle and hypokinesis. Then D, marked hypotensive response to nitroglycerin administration is consistent with this diagnosis. Yes, because nitroglycerin will cause vasodilatation, reduction in venous return. And so in addition to the fact that the nitroglycerin causes a vasodilatory effect, you will have even a more marked response to nitroglycerin administration, that is hypotensive response in right ventricular infarction. Then atrioventricular sequential pacing offers greater hemodynamic benefit. So in a situation where you need to do pacing, because the atrial filling, that 25% kick is very vital in RV infarction, knowing that it could cause a reduction in the LV output. and they have hypotension is the type of infarction in which you need to give IV fluid many times. So if you need to pacing of the atrium and the ventricle is very important in this instance rather than pacing the ventricle alone. So that option E is also correct. So the correct answer, that is the one that is false, is that option B. So V4R is the one that will show ST segment elevation rather than the standard V4. I don't know whether there are contributions. For question 207, so B is the answer. Okay, I'll go to 208. A 60-year-old man is admitted to the coronary care unit after 14 hours of chest pain that had resolved by the time of hospital presentation. The initial ECG reveals 0.5 millimeter ST segment elevation with T-wave inversion and pathologic Q waves in lead 2-3 AVF. The initial cardiac examination is unremarkable. On the second day, a faint late systolic murmur is heard at the apex, and by the third day, this murmur has increased to grade 3/6. The patient has mild dyspnea, and the chest radiogram shows pulmonary vascular redistribution. The most likely explanation for the murmur is, so this patient had an inferior infarction and then gradually developed this systolic murmur at the apex that increased to grade 3 by the third day. So this is in keeping with a mitral regurgitation murmur, and the options include A, ruptured posterior papillary muscle, B, ruptured anterior papillary muscle, C, infarcted posterior papillary muscle, D, infarcted anterior papillary muscle, and E, ruptured caudate tendinine. So, for because it was a gradual thing, that by the second day, let me see, okay, gradually increased from second and then to the third day, it was grade 3. I would go more with an infarction than a rupture. I think for a rupture, it would be more acute. It would become quickly obvious on auscultation, as opposed to this gradual way that it increased and became more audible. So I'll go more with an infarction. Now, I want to now narrow it down to which of the papillary muscles. Okay, so during my presentation yesterday, I talked about the fact that the posterior papillary muscle has a single blood supply, as opposed to the anterior papillary muscle that has a dual blood supply. The posterior papillary muscle is supplied by the posterior descending branch of the right coronary artery, while the anterior papillary muscle is supplied by the marginal branch of left anterior descending artery, and the branch of the left circumflex artery. So it has a dual blood supply. So the posterior papillary muscle is more prone to infarction. So the answer for this question 2 is infarcted posterior papillary muscle. So C would be the answer for 2. Any comment? Okay. I'll go to 209. Which statement about pericarditis and pericardial effusion in the setting of acute MI is correct? A, post-MI pericardial effusions are found most often in patients with large infarcts, in those with congestive heart failure, and in the setting of an anterior wall MI. B, early post-myocardial infarction pericarditis should be treated with non-steroidal anti-inflammatory therapy, e.g. ibuprofen plus colchicine. So this option is false. So for pericarditis with pericardial effusion can occur in different scenarios. So one of them is just post-myocardial infarction. There are other scenarios, pericardial TB pericarditis. So in other things, apart from post-myocardial infarction, yes, NSAIDs can be used, ibuprofen, colchicine, but in the scenario of post-myocardial infarction, aspirin is usually what is used. 650 milligrams, I think 6 hourly. I can't remember the frequency, but aspirin is what is used in this setting and not ibuprofen or the other in case. C, when present, Dressler syndrome manifests within 1 week after infection. So Dressler syndrome is, so we have an immediate post-termine pericarditis and Dressler syndrome that occurs within 2 to 6 weeks post-termine. So this option C is also false. I know of 2 weeks to 6 weeks and not 1 week after infection. D, tamponade due to pericarditis in the setting of acute MI is common. This statement is also false. It is not common. It can occur, but it is not a common thing. So I'm left with option A. Post-myocardial infarction pericardial effusions are found most often in patients with larger infarct, in those with congestive heart failure, and in the setting of an anterior wall myocardial infarction. And this would be the answer to question 209. Any contributions are coming or additions? Okay. I'll go to question 210. Which statement about conduction disturbances in acute MI is false? A, most patients with acute myocardial infarction and first-degree AV block have an intranodal conduction disturbance. B, sinus bradycardia in acute MI often results from increased vagal flow. C, of patients with acute MI and second-degree AV block, the majority have Moffitt type 1 Weckenbach block. D, Moffitt type 2 second-degree AV block occurs more commonly in anterior infarction than in inferior infarction. E, in patients with anterior infarction who develop third-degree AV block, the conduction disturbance almost always appears without prior intraventricular conduction abnormalities. So I'll try to narrow it down. So for inferior infarction, it's common to have an AV node affectation in them, and they will have the second degree AV block type 1, the Weckenbach phenomenon. And it's usually at the end of the day benign. With prompt management of the patient, it would most times gradually resolve and reverse with management. And so with inferior infarction, it's more commoner to have the Moffitt type 1 Weckenbach block, and it's commoner than the Moffitt type 2. So this option C is a true statement that of patients with acute MI and second degree AV block, the majority have Moffitt type 1 Weckenbach block. Then the option D, Moffitt type 2 second degree AV block occur more commonly in anterior infarction than in inferior infarction is true. So the Moffitt type 2 second degree AV block occurs is more common in the anterior infarction compared to inferior. Then sinus bradycardia in acute MI often results from increased vagal tone. It's a true statement. Increased vagal tone mostly is responsible for sinus bradycardia in myocardial infarction patients. Then I'm left with options A and E. E, in patients with anterior infarction who develop third degree AV block, the conduction disturbance almost always appear without prior intraventricular conduction abnormality. It's also a true statement. So most of the patients that had the inferior infarction, they may progress, they may have had the grade 2 before they now have the grade 3. But for anterior infarction, you can just have the sudden onset of a third degree AV block without prior intraventricular conduction abnormalities. So the answer to this question 210 is A. Most patients with acute MI and first degree AV block have an intranodal conduction disturbance. Which is false. I'm sorry, I'm trying to check again. I think I made a mistake. Because option A is also most patients with acute MI and first degree AV block have an intranodal conduction disturbance. That option is also true. I welcome assistance there. I'm in between A and E. Can I have contributions for question 210? I'm in between options A and E. I know C is true, D is true, B is also true. Hello?
Hello, from the option at the back of the
We are
book,
hearing you.
we
Go.
actually
Okay, go
said the
ahead.
answer is E. Except
Okay.
that, yes, from what is written in the
It's a
back of
false
the book,
statement.
it said it was stated that patients with anterior infarction may develop
Okay.
third-degree AV block without warning. However, it
Yes.
is usually preceded by less advanced conduction abnormality, such as Mobitz type 2, such as the Mobitz
Okay.
type 2 block. So I
Okay.
feel, and they said the answer here, option E is the answer. So I think,
Okay, yes. Now I get where I got confused. I'm looking for the false statement. All the other statements are true. Okay, yes. So it's this option E that is the false option. All the other options
please
are true.
explain it again. Please just.
Okay. Okay. So I will start with C and D. So that in inferior infarction, they usually are complicated by an affectation of the AV node, and they would present with morbid type 1 block, the Weckenbach phenomenon, mostly more than the Weckenbach type 2. So they can have first degree AV block, and also they can have the second degree AV block morbid type 1. Then in anterior infarction, they tend to have the morbid type 2 second degree AV block, that is the type 2, as opposed to the type 1 in inferior infarction. So those statements, question C and D, they are true statements. Then option B, sinus bradycardia in acute myocardial infarction often results from increased vagal tone. So there is usually an increased vagal tone post an acute onset of a myocardial infarction that can make the patient to have sinus bradycardia, apart from affectation of AV node. There can be an increase in vagal tone that can lead to sinus bradycardia, and this B is also a true statement. So B, C, D, they are true statements. Then option A, most patients with acute MI and first degree AV block have an intranodal conduction disturbance. So that intranodal conduction disturbance may be because of an affectation of the blood supply to the AV node, which we find in inferior infarction, where there is an affectation of the conus of the branch to the AV node. For example, if it's a right coronary causing inferior infarction. So that statement is also true. So most patients with acute MI and first degree AV block have an intranodal conduction disturbance. So we're not left with option E. So in E, patients with anterior infarction who develop third degree AV block, the conduction disturbance almost always appears without prior intraventricular conduction abnormalities. So a peculiarity of patients with anterior infarction as opposed to ones with inferior infarction is that they can go straight on to develop a grade 3 compared to the ones with inferior infarction, which they may have from first degree AV block, they can go to morbid type 1 or type 2 and then go to grade 3 AV block. So I don't know if there are other my colleagues.
What you just said now is true. That's the confusion. Do you understand me?
Yes.
Let me explain. I think the difference is that what she's saying is true, but just that he said almost always appears without prior intraventricular conduction. So it's not almost always, because he said most times it happens without any prior intraventricular abnormality. But they said third degree AV block. However, when it occurs, it's usually preceded by less advanced conduction abnormality. So the person probably had a Mobitz type 2 or type 1 before the infarction occurs.
So it's almost always that makes it false.
Yes.
So they can't actually have a prior type 2 or type 1 before the third degree, but the almost always is what is false. It's not an almost always thing. They can go straight on to grade 3 without a previous.
Hello, and good evening. Hello?
Yeah, go on,
Hello?
please.
And then in addition, one characteristic of Mobis type 2 is they can actually proceed to more advanced outdoor AV block. Like they can even have a Damstokes pattern. They can have a third degree, high degree AV block. Why in type 1, they don't usually go to advanced atrioventricular block. So I think they almost always, like you said, because it's very common characteristics of Mobis type 2 that they advance to more advanced AV blocks.
AV block. Okay, thank you. So that's the last question, Imam.
All right, thank you very much, Dr. Kedara. Thank you for excellent presentations. Right, so I don't know who is the next person who is taking 211. Let me check the chat box. I know Dr. Eugene put it on the chat box. Okay. I believe you have done 211. Who is supposed to take 211? If not, Dr. Mohammed, are you around?
Yes, I'm around.
Okay. So you're okay to take your own 216 to 220?
Yes, please.
All right, thank you. All right, so you can go ahead.
Okay, good evening, consultants and colleagues. I'll be taking question 216 to 220. Question 216. Which of the following statements about the arrhythmia illustrated in figure 2.4 observed in the setting of an acute myocardial infarction is not correct? A. This reading is associated with increased mortality. B. This reading is observed in up to 20% of patients with acute MI. C. It often occurs as a result of slowing of the sinus reading. D. Approximately 50% of such episodes are initiated by a premature beat. E. This is the most common arrhythmia after reperfusion with fibrinolytic therapy. So I don't know if you can scroll. Okay, so looking at this ECG, there's no, I can actually say it. Okay, there's no reading strip, but looking at V1, you see that there's an initial P wave at the first QRS complex with widened QRS complex. Then the second wave, QRS, there's no preceding P wave. And the third complex, so there's no preceding P wave. Fourth, same. Fifth, same. Sixth, same. Seventh, none. Then there's effusion beat, and that's around the 8th. Then the 9th one, there's sorry, it's the second to the last. That's what I'm saying. Yes, like that's more like the fusion beat. Then after that, that one, it's the next thing that it, especially in lead 2, looks like a captured beat because it has an upright P wave and then a narrow QRS complex. The rate it's about so I think about 85. I'm not sure. Let me just calculate that. About 85. So looking at this, with the frequent ventricular contractions and the dissociation between the AV dissociation with widening QRS complex. This is looking like a ventricular escape reading. Now, to narrow it down, you need the rate to distinguish whether it's ventricular escape reading, a accelerated idioventricular reading, or a ventricular tachycardia. A ventricular tachycardia will have the same widened QRS complex, and but the rate is usually more than 100. If you have a rate of between 50 to 100, it means it's an accelerated idioventricular reading. Then if it's between 20 and 40, it just means it's an ventricular escape reading. So for this patient, the rate, I said, is about 85. Let me calculate to be exactly sure. Then 1.5 divided by 18, about 83. That's 1.5 divided by 18. So with this, it shows that most likely is this reading is an accelerated idioventricular reading. The mechanism through which this happens is if there's a increase in vagal tone or increase ventricular automaticity. And this occurs most times when there's reperfusion, and it's said to be a marker of good prognosis, meaning that there's the area is viable and it has been reperfused. It can also happen in about 20% of post-MI. Other causes include drugs like digoxin. So with this background, I'll go back and answer the questions. So can you scroll up? So question A says this reading is associated with increased mortality. It's mostly benign, and the only time where it doesn't resolve spontaneously is usually complicated by hemodynamic instability. And in these cases, the treatment of choice is use of atropine or pacing. So option A is false. B, this reading is observed in 20% of patients with acute myocardial infarction. I said that's one of the causes. It can occur in myocardial infarction in 20% of cases. So since it's a true statement, that makes it false. C, it occurs as a result of slowing of the sinus reading. Yes, increased vagal tone, as I mentioned earlier, could cause when the SA node is not depolarizing as fast as it should, the ventricles takes over. And so because this statement is true, that makes it false. Option D, approximately 50% of such episodes are initiated by a premature beat. This is true. It's a true statement. So that for this option, it makes it false. Option E, this is the most common arrhythmia after reperfusion injury. So I had mentioned that this occurs commonly during reperfusion injury. So that's why the answer for this option is false. So for question 1216, the option approximately 50% of such episodes. Hello? Hello?
Go on. You can
Hello?
go on. You can go on.
Oh, okay. So, sorry. I couldn't. I thought this. So, so this reading is associated with increased mortality. So I said that's this option. Mostly the reading is benign, and it's not associated with increased mortality, except if it's complicated by hemodynamic instability. So for question 216, the answer is A, because option B, C, D, and E are true statements. So because we are looking for the incorrect answer, it makes it B, C, D, E false, and then A true.
Yeah. Thank you. I wanted to ask you something. You know, when we saw the image, you said this
Yes.
is a capture bit. I don't know which one you call the capture bit. I think it's
Okay.
this one.
Yes. Yes. That's what because there's a preceding P wave. I don't know if it's in this thing I'm overstretching.
Well,
but
although we are not seeing the full, do you understand me? But
yes.
if they prolong, if the other parts of this place are like sinus rhythm, do you understand me?
Yes.
If it continues, what if this rhythm has actually normalized? Or I don't know whether you get my point. This idioventricular rhythm has shifted to a sinus rhythm or a normal sinus rhythm. That's also a possibility. I don't know. I don't know what you think or what the class thinks.
That's why I'm saying that it's now a captured, because if the first one was because it's looking more like both the one before this one is looking, there's no preceding. Yes, there's no preceding P wave, but it's narrow complex. So I'm thinking that's a fusion bit where there's depolarization of both the SA node and the ventricle.
I agree with that one. Yes.
So now,
But
this
a
captured.
fission bit will not. What's the right word to use now? Okay, maybe if I may ask, what's the capture bit?
Okay, a captured bit I feel is okay.
A capture bit is when in like a ventricular rhythm, there's a transient electrical activity through the sinus node, and it just captures it in the midst of that ventricular rhythm.
It goes from the atrium. You know, in VT there is AV dissociation.
Yes.
So at times there is a transport or a what's the right word to use now? There's a conduction of impulses from the atrium to the ventricle through the AV node. We now have the capture bit. That's why you have it as a narrow complex. Do you get my point now?
Yes.
Yes.
So what's the fusion bit?
A fusion bit is like when there's like a mixture of both. You have the ventricular complex and you have so it's like two of them are superimposed on themselves.
Exactly. So you can't have it as a normal QRS, PQRS. That's my point. So
Okay, that's true.
it won't look like this. Yes. So that's what I'm trying to explain. So it's difficult to say that first one is a fusion beat, like he was trying to explain, so that we don't get confused.
Yeah.
Yeah. So a fusion beat will have both your P wave and your KRS current like fused together. So it's still going to look bizarre, although different from the from an escape reading that you have on a ventricular tachycardia. It won't be like the normal ones that are preceding, but you will see an obvious P wave and a QRS complex looking fused together. While a capture beat, you see a QRS complex, let me put it that way, that has been conducted like we are conducting a normal PRS complex. Do you get?
Yeah, thank
So
you.
you cannot describe, so you cannot describe a fusion beat here. But it's possible to have your your reperfusion reading preceded like Dr. Okore was trying to say, preceded by a normal sinus reading subsequently. That means it might not be sustained, like he's trying to say. I'm not sure you get what I'm trying to explain.
I get what you're trying to say. So most likely it's a return of the sinus reading.
Exactly.
Yes.
So that's
Yes.
it. Thank you.
Yes. I understand.
Thank you, Chief. Thank you. Dr. Mohammed,
Thank you
can
very
go
much.
on.
Okay, so for question 216, we agreed that option A is the right option because it's mostly benign. Question 217, which of the following statements concerning the utility of cardiac biomarkers in patients with acute coronary syndrome is false? Levels of C-reactive protein are greatly elevated in patients with acute coronary syndrome compared to patients with stable disease. This option is true because it's C-reactive protein is used to predict long-term outcomes in acute coronary syndrome and coronary artery disease generally. And it's said to be increased as a result of inflammation of the atherosclerotic plaque. Option B, C-reactive protein and cardiac-specific troponins offer complementary information on the prognosis of patients with ACS. So we know that cardiac troponins are the highly sensitive cardiac troponins are the gold standard for diagnosis of acute coronary syndrome. However, they are not specific. Other things like chronic kidney disease and sepsis can also cause its elevation. So, but when we combine this with C-reactive protein, they complement each other and increase the prognostic value of these two markers. So, option C, patients with elevated B-type natriuretic peptide have a 2-fold to 3-fold increase in risks of adverse events. BMP is usually released due to an increase in the ventricular wall stress or volume overload, and it's a marker for ventricular dysfunction. When there's an increase in BMP in patients with ACS, it's said to increase the adverse effect by 2 to 3-fold. So that's a true statement. So because it's a true statement, That makes it false. The next option, sorry, I can't see. Option D, patients with non-ST segment elevation MI and elevated white cell count have similar mortality rates as those with normal white blood cell counts. This answer is the true answer, because it's been said that patients that have elevated white cell count in non-ST segment elevation had worse prognosis when compared to those that had normal white blood cell counts. So this is a true option, because this statement is false. They don't have equal mortality rates. Those with elevated white cell count have worse prognosis compared to those with normal white blood cell count. Okay, question 218. A 76-year-old man with permanent non-valvular atrial fibrillation, hypertension, and peripheral artery disease presents to the emergency department with anterior chest pressure of 2 hours duration and medications. Okay.
How about that? Just go on. Maybe when you reach the end of this page, I'll shift to the next page. Yeah.
Okay, her medications include apixaban 5 milligrams BD, metoprolol succinate 100 milligrams daily, indapamide 2.5 milligrams daily, and atorvastatin 80 milligrams daily. Initial vital signs are heart rate of 84 beats per minute, blood pressure of 149/86 millimeters of mercury, respiratory rate of 18 breaths per minute, and oxygen saturation of 97%. The ECG shows atrial fibrillation with a ventricular rate of 84 beats per minute. There are 2 millimeter ST segment depression in leads 2, 3, and AVF, which are new compared to the tracing taken 6 months earlier. Serum cardiac troponin T is elevated at 1.3 nanogram per ml, and coronary angiography, there is 95% stenosis of mid-right coronary artery, which is treated with drug-eluting stent. In consideration of subsequent medication, which of the following statements about combined anticoagulant and antiplatelets is correct? A, oral anticoagulation therapy plus clopidogrel without aspirin, that's the double therapy, significantly reduces bleeding rates compared to triple therapy of anticoagulant with dual antiplatelets and aspirin and clopidogrel in patients with with need for long-term anticoagulation who undergo PCI. So this option is true because okay, let's just start. The CHA-2DS2-VAS for this patient is 4. The age is greater than or equal to 75. She's 79, so that's 2. She's hypertensive. That's 3. Then she has peripheral artery disease. That makes it 4. Using the older CHA-2DS2-VAS, because of the sex category, she would have had 5. So for this patient, she has already had a PCI, and the question is trying to the long-term management, whether to use dual direct oral anticoagulants and single antiplatelets or dual direct oral anticoagulant and dual antiplatelet. So for option A, for this patient, they said oral combination of anticoagulant and a single antiplatelet is reduces risks of bleeding compared to triple therapy. So for this question, it's option, it's true. According to the WAS trial, it was said that combination of direct oral anticoagulant and single antiplatelet like clopidogrel for 1 year was reduce the risks of complications, adverse outcomes like myocardial infarction and other cardiovascular risks, and had less risks of bleeding. So that's what led to the new ACS recommendation, ESC 2024 guideline, made this a class 1A recommendation. So option A is true. Option B, rivaroxaban 15 milligram daily plus a P2Y12 receptor inhibitor has been shown to be beneficial as the combination of warfarin plus dual antiplatelets, that's aspirin and P2Y12 inhibitor, for prevention of ischemic events in patients undergoing PCI. So according to the Pioneer trial, Pioneer AF trial, that's prevention of bleeding in patients undergoing PCI. This trial had 3 arms where the vitamin K antagonist plus dual antiplatelets was used in 1 arm, and then the second arm, low dose rivaroxaban of 15 milligrams plus P2Y12 were used. Receptor inhibitors were used, and then the third arm, low dose rivaroxaban between 2.5 to 5 milligram BD plus a P2Y12 receptor inhibitor were used. So it was this was just to the outcome of note was to check if any of them was inferior to the other in terms of bleeding outcomes. But it was not powered to check for ischemic outcome. So that's why option B is false. Then option C, after an acute coronary syndrome, the addition of low-dose rivaroxaban to aspirin inhibitor, to aspirin plus a P2Y12 receptor inhibitor reduces the risks of cardiovascular death, non-fatal myocardial infarction, or stroke without increasing bleeding risks. So this option is still with reference to the Pioneer AF trial. Like I said, this was the third arm of that same study. And the only thing that was checked in that study was bleeding outcome. And he had, it wasn't powered to check for these other outcomes, the ischemic events in the descent. So that makes it false. Option D, substituting rivaroxaban 2.5 milligrams BD for low dose aspirin following recent acute coronary syndrome reduces the rate of cardiovascular death, but increases the bleeding risk. This is making reference to the Germany ASC 14 guideline trial. In this trial, rivaroxaban was substituted for aspirin with no change in the bleeding, but the efficacy was not proven. So option D is false because the efficacy was not proven, but this option says that recent ECS reduces use of this substituting rivaroxaban for aspirin reduced the rate of cardiovascular death, but it wasn't shown to have any efficacy. They all had the same outcomes. The cardiovascular outcomes were the same. So that makes it false. So for this question 218, the correct answer is A.
Thank you so much, Dr. Mohammed. Please, because
Yes.
I want to understand something here. So that's why I'm going to ask this question. So for
Yes.
this kind of patient now who has
Yes.
an indication for long-term anticoagulation because of
Yes.
atrial fibrillation, Chadva's criteria, Chadva's community criteria. Now he also has an indication for dual antiplatelet therapy. So putting all these things together now, what combination of anticoagulant, antiplatelets will be best for him? I don't know whether you understand my question. Putting both the benefits, the risk of bleeding, according to just what combination will be best for him. I don't know if you understand the question. I don't know.
Okay, rivaroxaban and clopidogrel.
Rivaroxaban and clopidogrel, no aspirin.
No aspirin.
Okay. All right, thank you.
So question 219. Which statement about the progression of atherosclerosis after coronary artery bypass graft surgery is false? A, between 15 and 30% of vein grafts occlude by the end of the first year after CABG. B, the annual rate of saphenous vein occlusion between years 2 through 5 years after CABG is approximately 2%. At 10 years, the overall occlusion rate for a saphenous vein graft approaches 50%. D, the atherosclerotic process that occurs in venous grafts is histologically distinct from that which occurs in native arterial vessels. So it said that 15 to 30% of occlusion occurs in the first year. After the first year, between 2 to 4%. But at the 10th year, it's estimated that about 40 to 50% is occluded, of the saphenous vein is occluded. And histologically, the atherosclerotic process between the graft and the native vessel is indistinguishable. So for this question, because the the correct option here is D, because histologically, the atherosclerotic process that occurs in venous vein grafts is histologically distinct between from that which occurs in native vessels. So this is the false option, because histologically they said venous grafts, you can't distinguish them from the natural arterial vessels. So that's why this option is the true option. So option A is false, B is false, C is false. Question 220. Which of the following statements regarding myocardial stenosis is not correct? So myocardial stenosis basically is a state of prolonged but reversible myocardial dysfunction, despite restoration of adequate blood flow. And usually it's caused by an acute hypoperfusion. So going to the options, option A says stenosis is a state of depressed myocardial function due to chronic hypoperfusion. So looking for the incorrect option, that is true, because the cause is usually from acute hypoperfusion, not chronic. Chronic usually happens in hibernation. Option B, stenosis can be global or regional. This is a I can see. Okay. Stenosis can be global or regional. So this is true. So that makes it false. Stenosis can follow cardiac surgery or cardiopulmonary bypass. Yes, this is a true statement. So it's false. Can also happen after a cardiac arrest, or oxygen free radicals and excess intracellular calcium likely contribute to stenosis. This is one of the mechanisms for which stenosis occurs. E, stenosis affects both systolic and diastolic function. Yes, this is true, a true statement. So since we're looking for the false statement, that makes it false. So option A is the false statement. That makes it true. B, C, D, and E are false because they are all true statements.
All right, thank you very much, Dr. Mohammed. Thank you so much. I don't know any comments or questions for Dr. Mohammed before we move on. I don't know what the class thinks. I wanted us to finish his own part so we don't cut him halfway. But I don't know whether we call it. I don't know whether we call it off for the night or we continue.
No,
Please call it off.
Yes, call it off.
All right, so call it off for the night. Chief Alison, please, are you still around? Any final words for the class, ma? Okay.
Can you hear me?
Yes, ma, we can hear you.
Yes. I'm still with you, but the consensus is, I think they want to call it off. So I go with everybody. So well done. Just to encourage us to keep pushing. Then I would say that what was the right word to use now? Don't be discouraged. The journey is still far. So you should pick up as many things as you can pick up now. Because as the days comes closer, you become so tired and fatigued. So let's try and maximize this time so that when the chips are down, at least we'll have something in the back end. So that's what I would say. Make sure we check her book. At least you must read your book once in a week, minimum of once in a week. And as you are reading, please make corrections and start typing those corrections so that you can print out weeks before the exam. It will be overbearing if you don't start now. So make your corrections. By the time you read it, any typo errors you are seeing, start noting them. And if possible, start printing them out so that when exam is near, you are not overwhelmed with so many things to do. And so please too, let's not forget her general medicine. Minimum of 1 hour in a day for your general medicine is mandatory, please. Different from the general medicine group, the questions that you answered there. Because now it's not really emergency medicine that they bring out. So you need to read as many things as you can. You never can tell where the questions will come from. There is an outbreak of Lassa fever in Ondo State now, which is the highest state with recurrence or worldwide now, nationwide from WHO, and they are currently investigating now. So please, Lassa fever is never outdated, viral hemorrhagic fever as a whole, but Lassa fever, please, let's read and reread. Meningitis, please read and reread. And in meningitis, so you know there is a new guideline for management now, where it must include vancomycin, especially in this part of the world where we have methicillin resistance. So it's part of the first line. So all those little changes like that are the things you want to hear. So please read general medicine every day, please. It's so that it won't be a setback for us. Well done, everyone. Thank you.
Thank you so much, Chief. Thank you. All right, everybody, thank you. Remember, we have a guideline presentation tomorrow. We start at 6 p.m. All right, see you all tomorrow. Thank you.
Thank you, Charles. Grateful. Thank you, Dr. Alison.
Thank you, Eugene.